So a little bit of history on progressive orthodontics. This is Don McGann. He founded this company back in 1984, and we've been the leader in orthodontic education for general dentists ever since, so over 40 years. Very dedicated. He continues to mentor students and come to some of our courses, and just has really established quite a global presence. You know, I mean, you wouldn't know it by looking right here in Orange County. I wish we had more people that were interested in this area and coming, but you know, later this month I'm going to be in Spain, and we'll have a whole complete room full of people in Spain. We'll be in Amsterdam, and you know, we have courses all over the world where we have doctors that come and learn how to do aligners and brackets from us. So it's a global company. We have instructors who are general dentists. Some of them are actually pediatric dentists who do ortho. A few of them are periodontists who do ortho. Some of them are prosthodontists who do ortho. So these are all people who trained with us, and most of them general dentists. Some of them are specialists in other areas, and they do ortho in their practices, and so they teach with us. Our mission is to provide complete orthodontic system for success. Like, we're not going to teach you just like, oh, well, here's how to do a little bit of ortho. We want to teach you how to do everything there is to do, and then you get to decide what fits well in your practice based on how busy you are, where you're located, and what's interesting to you, you know? So for me, I found that I'm a busy enough practice that I want to do the cases that are going to be financially productive, that are going to be fun, that I know we're going to get a good result from, so it's positive for my patient, positive for my staff, positive for me. And the cases that I can see a headache coming, I just let the specialist treat those cases. So, but then there's other dentists who work with us who enjoy taking on every case. And they take a lot of pride in treating everything and referring nothing. You know, so whatever level is a good fit for your practice, I feel like you will have the education if you decide to invest in education with us that will take you to any level that you want to do. We have some doctors who, even though they don't advertise themselves as being, good morning, thanks for joining us. Fine, good, come on up front. They actually only do ortho. So they're not specialists because they didn't go through a specialist program, but they only do ortho. They work for other dentists, you know, they literally just do ortho. So a wide range of what's come out of our training for people, but we really are a family, you know, we're kind of a little cult, you know, where we just, people who come here get so into it that we feel like, you know, you go through a 2-year program, you become really good friends with the people in your program, and we do have quite a family. So our teaching philosophy is to share everything we know. And I think that's one of the differences as you go to somewhere where an orthodontist is teaching, and it's like, well, you're general dentist, so I'm going to teach you this, but I'm going to keep what I know to me. And that's not how, you know, we want you to know everything we know. And so with that, we're going to show you lots of clinical cases, and they're not always just going to be the ones that came out really well. Because you guys know, like, you sit down and start working, you do crown preps on somebody, and you're going to have one that you're really proud of. It came out really well for whatever reason. You were just having a good day, the patient was really cooperative, you had good access, who knows what it is. And you're happy to put that up on a screen and show everybody. And then we've all had cases where you're like, I don't know if I was having a bad day, if the patient was just hard to, whatever the situation was, we got it done, but I wouldn't want to put it up on a screen in front of everybody. Right? But we want to show you the cases that came out good and bad so that you can learn, because we don't learn just from seeing good cases that always worked. We need to see, like, well, where are the struggles? Where are the challenges? Where are the things that you had to figure out how to get the case done because things weren't going the way you wanted them to? That's reality. It's what happens. So we're going to show you all kinds of cases in our seminars. We always make sure you have more than one instructor, because I have one way of explaining things, I have my experience, but when you get another instructor in here, they'll explain maybe the same concept, but in a way that just clicked for you, that made sense. Or they'll have pearls or little things that they do in their practice that maybe I don't do. And so having a variety of instructors is really helpful to build your education. We are really committed to using modern technology, so you're going to see some stuff today that I'll introduce that hopefully you can take away, and even you guys who have experience where you're like, wow, this is actually a great tool for me to use. And then we really encourage doing cases. Some of our doctors during the 2 years that they train with us will start over 100 cases, 150 cases while they're doing this with us. I kind of compare it to like, if I'm going to teach you guys how to sail, does anybody sail boats? No? So imagine that we're going to go learn how to sail. And we sit here for days and days and days and talk about all the lines and ropes, all of the different cables and all the different pulleys and all the sails and all the stuff. And we talk about it all. And you're like, okay, that's all really good. But when are you going to learn how to sail is when you go get in the boat and you go get under the wind and you go learn how all of this stuff works. And then if we get out of the boat and come back in the classroom and start talking about it, you're going to start really paying attention because you're like, yeah, I had that problem out in the boat. I didn't know what that was for. That would have really been helpful to know. So we really learn when we start doing it. And so when we're in our courses, we get you started in cases right away so that as you come to the courses, everything we're teaching is making a lot more sense because you're actually doing it in your practice. You do a crown prep, you have to know how to do that from start to finish because you're going to start and finish on that patient. With ortho, all you need to know initially is what kind of a case am I looking for? How do I take pictures and get records so I can start? And then all you need to know is how do I put brackets on the teeth? And because it takes 18 to 24 months for you to treat a case, even same thing with aligners. It's going to take a while to treat the case, so you can be learning during that 2 years that you're treating those cases, and that's the best way to learn. We also have consultants and mentors. Okay, so the instructors also offer a service to do consulting and mentoring. That's what gave me the confidence in my practice to look at a patient, even though the only person I've ever put brackets on is my mother-in-law, but I can look at a patient and go, hey, we're doing orthodontics in my practice now. I think you'd be a great candidate. Love to be able to do your braces for you. And in my head, I'm going, I have no idea what I'm doing, but I know I have a mentor who's going to guide me every step of the way to make sure I do a good job. And now I can look at my patient and confidently say, we do braces in our practice. Instead of like, oh, maybe, I don't know. Like, no, we want to have confidence and know that somebody's going to help us all the way through. And then we also have a free lifetime retake policy, which means you sign up for a course, you take the course, you can have access to that course for the rest of your life. You can come back with no tuition to any one of the courses. And some of our doctors will actually take vacations to go, travel to some of these worldwide destinations, Australia. I have this one gal who I see her all over the place. She shows up in Singapore, she shows up in Australia, she shows up in Spain. She's like, just wherever you guys are teaching, I just make a vacation and go there and come to one of the courses. So free lifetime retakes. Let's talk for just a second about what orthodontics is for those of you who are new to ortho. So diagnosing, preventing, and correcting misaligned teeth. If we look at our patients, 95% of our patients have some level of misaligned teeth. We call it a malocclusion, okay, a bad bite. There's very few people that when you look in their mouth, you're like, everything's perfect. All the teeth are lined up perfect. And before I started doing ortho, when I would look in people's mouths, I was looking for cavities, I was looking for broken fillings, broken crowns, I was looking for cancer, I was looking for periodontal disease. I really wasn't paying much attention to the bite, to the crowding, to whether they were open bite in the front or deep bite in the front. Like, it just wasn't on my radar. On the kids, the parents would be like, does my son or daughter need ortho? And I'm like, yeah, it looks like their teeth could be straighter. That's all I could see. Looks like they could be straighter. So here's a referral to an orthodontist. And if it was an adult, frankly, I didn't bring it up unless the patient brought it up. It wasn't part of my exam. It wasn't part of talking about what the conditions in their mouth were. So unless they said, what about my crooked teeth? Oh, yeah, sure, go see an orthodontist. But it wasn't part of my evaluation of that patient. Even though now I look at it and go, how could I not evaluate that? That's a massive part of what's going on in that patient's mouth, is this dynamic, how this all fits together. So controlled forces that are applied to teeth to create tooth movement. So how do teeth move? Teeth move when there's a force applied. In fact, patients are doing ortho on their teeth all of the time, even without orthodontics appliances. Okay, why do people's teeth move over time? Why do they shift over time? Why, if we put a new restoration in, will they come back and now they're trapping their sandwiches in that spot where you're like, I know there was a contact there when I was done with that crown, and now they come back and they're like, oh, hey, I'm getting, all my meat gets stuck in that spot. And you're like, well, they moved the tooth. How did they move that tooth? Why did that tooth move? So teeth move when there's a constant force, and they move until the force goes away. So that new crown that we put in, there's something about one of those inclined planes that when that patient bites, there's a constant force, and every time they swallow, especially your stronger muscle patients, every time they chew and swallow, there's a force being applied that's causing that tooth to want to move. And the tooth will move until that force no longer exists and it finds equilibrium, it finds balance. And when it finds balance, then it finally stops in that position where there's no longer any forces being put on it. When people get older, they lose the elasticity in their lips. Their lips become a little bit more tight. And so through tighter lips, there's more force on the teeth, pushing them back. And so as people get older, sometimes we'll see more crowding in the front of their mouth because their lips have become less elastic. Or maybe somebody has a big tongue and they're constantly pushing on the back of their teeth, and their teeth just keep splaying out further and further like this. So anytime that there's a force on teeth, the teeth will move, whether it's coming from their tongue, or whether it's coming from their lips, or it's coming from a thumb that they're sucking on, or it's coming from a lip that they like to suck on, or it's coming from their bite. Like, teeth will move as long as there's a force that's constantly on them. And they're moving until they find a place where there's balance. So teeth are where they are because they found balance between the forces of the muscle, which is the tongue on the inside, and the lips on the outside. And then when they bite, everything fits together in a way that the forces are balanced. Okay? And so when we do ortho, we're just putting basically muscles in there. We're putting forces intentionally to get things to move. But the cellular biology, the body doesn't know where the forces are coming from. It just knows there's a force there. And so it has to do things to allow the teeth to move so it will go away. So with braces, we put brackets on the teeth so that we have a little handle on the tooth so that we can guide a wire through there that can put a force on that tooth. And with aligners, we use a series of plastic trays, and each different tray can put more and more force on each tooth so that the teeth have to move and move and move, and every tray moves the teeth based on some forces. So all we're doing is applying controlled forces to the teeth. Then we get to retainers, and retainers are supposed to be passive. They're not putting forces on the teeth. They're to help establish a position that we want to maintain, which is why we call them retainers, right? And some patients want you to fix their teeth with retainers. You're like, no, retainers are retainers. We fix teeth with orthodontic appliances, even if it looks like a retainer. But our goal of ortho is to improve their alignment and make them look better and make them function well. Okay, so aligners, biomechanics is a series of clear trays that we wear sequentially, and each tray has a certain amount of movement. So maybe 0.2 millimeters of linear movement, maybe 1 degree of rotation, maybe 0.2 millimeters of intrusion or extrusion, small amounts of activation, and when the patient puts in a new aligner, snaps it into place, that new aligner is slightly deformed because it wants the teeth in a new position. And so when they put it in, the plastic is kind of bent out of shape a little bit, and that deformed plastic that wants to go back to its original shape is what's providing the force. And then when the teeth finally move into the position of that aligner, now there's no more force, and the patient can feel, hey, my teeth aren't moving, I don't feel any more pressure on my teeth. And then they move on to the next aligner. Okay, so that's how the biomechanics of aligners works. And there's things that aligners are really good at. There's forces that the aligner can apply well to the teeth. It can push the teeth out really well. Anywhere where it can touch the tooth, like the buccal and lingual surface, the occlusal surface, it can apply forces to move. But there's other things it has a hard time doing, like extruding a tooth. So pulling a tooth down, aligners have a hard time doing that because there's nothing for it to push on. Whereas braces can do a really good job of extruding a tooth because you have a handle on it and you can run a wire up to it with some anchor teeth down here, and that can apply a force to bring the tooth down. So brackets and aligners work differently. And what one is good at, sometimes the other one's weak at. And so for those of you who are maybe only doing aligners, which was me initially, and we get a lot of doctors in here who are like, I've done a lot of aligners. You're a lot of aligners, but not done brackets, right? And they're like, I just feel comfortable in aligners, and I only want to treat cases with aligners. And I'm like, yeah, but brackets are so efficient. And even if you finish all your cases with aligners, there's a lot of cases you'll want to start with brackets because it's so efficient. They're so good at doing certain things that aligners just have a hard time with, that you can open up a whole new world of cases when you start being comfortable. And it's like, well, why won't you put brackets on? Just because I'm not comfortable. And it's like, well, I don't only treat the cavities that come into my practice that I can treat with a slow-speed handpiece. You know, like it's way more efficient to use a high-speed handpiece. But it's scary to use a high-speed handpiece until we get it in our hand and start using it. And after we use it a lot, we're like, all right, I'm comfortable with this instrument. I can start using this. But initially, it's scary to use a high-speed. Do you guys remember the first time you took a high-speed on a patient's actual tooth in the clinic? It's scary. We're like, zzz, zzz, you know? And then after you get comfortable with it, 2 or 3 years into your practice, you cut a crown, you're like, you know? That's not how you started, though. You started just like, little tiny, touch it. You're so scared of it. And it's the same way with brackets. The first time you put brackets on the case, you're like, oh, this feels so scary. And then later on, you're like, slap some brackets on there. Let's get this thing opened up and let's unravel this mess. And then we can switch over to aligners. And so when you start to see that, hey, aligners and brackets are just 2 different tools in my toolbox, what I know is how to move teeth. You get very efficient and you get really good at treating cases using both of these. With aligners, we have to have them 22 hours a day, because if the force is not there constantly, then the teeth don't move. And that's one of the challenges with aligners is, why did that case go so well, and why is this case struggling? Because both patients will sit there and tell you, I wear my aligners all the time, doc. And you're like, well, why is this one working and this one's not working? And one of the variables is, this guy really does wear his aligners 22 hours a day, and this one only has it in about 8 hours a day, because he's constantly taking them out and finding excuses and forgetting. And even though they both sit there and tell you that they're wearing them all the time, the actual different amount of time that the force is being applied is wildly different. And then certain movements require more force. Okay, so with aligners, movements that the aligner is just not able to apply enough force will add buttons and chains and auxiliaries, things that can increase the force being applied by the aligner. So we'll do things like class 2 elastics. We'll do things like vertical elastics, things that allow forces to be put onto the teeth that the aligner just isn't capable of putting on in enough degree to cause the change that we want. Aligners require intimate contact with the tooth surface. So if somebody has small clinical crowns, and the clinical crown, like the height of contour is under the gum line. You guys know what kind of patients I'm talking about, right? Aligners will work very differently on that patient than on the one who has big clinical crowns. And when they put the aligner in, there's a huge crown there, and it has the height of contour that it can snap onto. On that patient with big clinical crowns and with undercuts, essentially, where the height of contour is well out of the gum tissue, their aligner treatment will work much better than the patient who has small clinical crowns and the height of contour is at or below the gum line. And so even though you're like, oh, I do aligners on a lot of patients, well, are you noticing the difference between how much tooth surface you have to work with and how retentive the aligner is on one patient versus another? Because if you have a patient with big clinical crowns with undercuts, when they put their aligner on, it snaps into place. And so it really can apply pressure to the teeth because it has lots of surface to work with. On another patient, when they put it in, it just doesn't snap on. And there's not a lot of surface area to apply force to move the teeth. And so even that's a variable that can make one case work well and another case not work well. Whereas with brackets, as long as there's enough enamel exposed for me to bond a bracket to, the force that's applied when I put a wire through that is exactly the same, whether there's a lot of clinical crown or very little clinical crown. So there's differences between the appliances. Also with the braces, they're on 24 hours a day. Unless the patient goes in the garage and gets out pliers and rips them off, they're not the ones deciding how often the force is getting applied. The force is not going away. It's there 24 hours a day. So compliance can be an issue. And we can find that we get better results sometimes with braces just because the force is there all the time. So when I'm sitting there working with a teenager and I'm not seeing the teeth move well with the aligners, I'm going to pull out brackets. Or at least I'm going to threaten to pull out brackets. And when he's like, because I do brackets, I'll be like, hey, I don't care. Your parents paid for your teeth to be straight. So if you're not going to wear the aligners, we're going to put brackets on. And sometimes that's enough motivation to get them to start wearing their aligners. And sometimes it isn't, and then we put brackets on. And we finish up the case with brackets. But if I don't have brackets in my back pocket as a tool that I can pull out, and I'm not comfortable with them, what do I do on a case that the patient's not wearing their aligners very well? Just say, bummer, do I refund money? Like, what do we do? So learning how to use both of these is really valuable. And we've gone through and rewritten our entire series of seminars that we teach because, we've been around for a long time, and it used to be that brackets was the only way to do real orthodontics. And so our traditional course was brackets, 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 brackets. And then aligners are kind of over here on the side. But the reality is, that's like you going to dental school. I never did a posterior composite in dental school. Do you guys do? What did you graduate? Did you ever do a posterior amalgam in dental school? Okay. But they let you do composites too, right? Okay, see? So when I graduated dental school in the year 2000, we never did any composite except on the front teeth. And then they send us out into the real world, and it's like, nobody's doing amalgams on posterior teeth. Everybody does composites on posterior teeth, but we never even did one of those in dental school. So when you come, we're not just going to only teach you brackets, because the reality is patients demand aligners. Aligners are being used a lot all over the place. So for us to just teach you brackets would be an oversight. So we've rewritten and put aligners and brackets all the way through. And in fact, what we're finding on most of our cases, if we want to be the most efficient, is we do both. We start with brackets. We call them hybrid cases. We start with brackets. We finish with aligners. And we're currently this year in the process of working with Medit. You guys aware of the Medit scanner company? And I'll show you a software that we've developed with them. But we're working with them to create a really great solution so that financially it makes sense to do hybrid cases. So that, because right now, if you buy the brackets, and then you put the brackets on, you use the brackets, then you have to go to Invisalign and pay $2,000 for the aligner case. That's expensive. But if we can say, hey, here's the brackets, you paid $150, $200 for the brackets, and then for $500 worth of aligners, you can finish the case, that all of a sudden becomes a nice option as opposed to like $200 for the brackets, $2,000 for the aligners. But when patients can get the first 6 months of their case done with brackets, and then take those off and switch over into aligners, it's good for the doctor, it's good for the patient, it works really well. So we're doing a lot of that in our teaching and in our offices right now. So brackets, same thing, we're trying to apply a force to the teeth. What are the biomechanics here? Well, when your patient comes in with all these crooked teeth, we basically attach a handle, which is the bracket, onto each one of the teeth. And initially, we put in this preformed flexible nickel titanium arch wire. It's this super flexible wire. It's in the shape of an arch, but you can literally take it in your hand and crumple it up into a little ball and then drop it on the table, and it just springs right back to its original shape. You can tie it in a knot and pull it and then untie it, and it will take its original shape. It's really malleable. It's really easy to move around. So you take it into a crooked mouth, and it's really easy to tie it either with steel ligature ties or with little elastomeric ties to attach it into each one of these different brackets. And here is a spot where it's too tight, so there's a coil here that's pushing the other teeth apart to make room for that tooth to finally get a bracket on it. But we're tying this really flexible wire that slowly, it has a light force that wants to go back to straight. So we tie it all crooked into the mouth, and literally the patient could go away for 4 months and come back with straight teeth. Mostly straight teeth, depending on how well you put your brackets on. Just because that wire it's a constant 24 hours a day, gentle light force, and your body just responds. It turns on the cellular activity, it turns on the osteoblast, the osteoclast, it eats up bone, it builds new bone and allows the teeth to move positions until the teeth are straight. And so the force, instead of coming from an aligner, the force is coming from a little wire that wants to be straight. And when you put it in the patient's mouth, it's not straight. So anywhere that it's deflected or deformed, there's a force being applied to get the tooth to go back to straight. So if I have a tooth that's up here, and like a canine that's kind of high that needs to come down, and my wire goes up to that and then comes back down, there's a force on that that wants to bring it down. If my tooth is rotated, and so when my wire goes in, the wire has to deflect to go into that rotation, that wants to derotate. And so the force for the mechanics is coming from this little wire, this little nickel titanium wire. It's revolutionary. That material revolutionized. There were two things that revolutionized orthodontics. One was bonding. Because I don't know if you guys ever have seen pictures, but way back, not that long ago actually, they had to put bands on every single tooth. Have you guys ever seen pictures of braces where there was a band on every single tooth? Have you ever seen a permanent retainer where they had bands on their canines that went all the way around? I've only seen a couple of those around, but not too long ago, 50, 60 years ago, I'm not sure exactly when it was, but if you got braces, you got spaces created between all your teeth, and every tooth got a metal band all the way around it. Because there was no way to bond anything to a tooth. You could only cement a band on a tooth. So it was revolutionary to be able to bond to a tooth. And now you just needed a bracket instead of having to have a whole band. And then they also used to use stainless steel wires. So any movement that was accomplished in the mouth came from the orthodontist bending a wire. So any rotation, any movement came from a bend in the wire. And so how skilled did the orthodontist have to be able to bend every single movement that they wanted into the mouth? That's why orthodontics used to be such a specialized skill, and why cases used to be so expensive, is because the amount of work and skill that went into it was massive. And so the things that revolutionized it were bonding brackets to teeth and this nickel titanium wire. So that instead of having to bend every single movement that you wanted, you could just put this wire in that was flexible and wanted to go back to being straight. It wouldn't permanently deform. And now all of a sudden, you could just put your brackets on the ideal position of the tooth and then let the wire do the work. Now, when you're going to finish the case with brackets, it matters exactly where you put the tooth or where you put the bracket. And so it becomes really important that you bracket, and that's what we teach in our course. How do you bracket this bracket perfectly on the tooth so that by the time the wire is straight, the tooth is also straight? And if you didn't get the bracket put on perfectly, when you notice the problem, you have to remove it from the tooth, clean it, and then put it back on in the right position so that it will actually straighten the tooth the right way. But if you're going to switch over to aligners, you just have to be close. Because if you can just be anywhere in the right area, then you're going to get a lot of change and a lot of movement, and then the little details, you're going to finish that up in aligners anyway. And that's what's great about doing these hybrid cases is you get to go in there and just put the brackets on. If you're not great at it, no big deal, because it's going to be better than it was when you started. And the wire gets all the cellular activity going, it gets the bone moving so that when you switch to the brackets, everything's already happily moving and ready to improve. So we start with this real flexible wire, and we do what we call the initial leveling and aligning. We get basically all the crowns will move to be straight. We can take, if you're good at it, you can take just about any case, unless the tooth is rotated backwards completely, you can, or you have a canine that's completely impacted. But in the hands of somebody who's good at it, you could take any case and get them to have straight teeth in 6 months with brackets. Now that doesn't mean that you can coordinate the arches, okay? And that's a different story. Coordinating the arches, like, well, the teeth got straight, but I've got a massive amount of overjet. So if I have to extract teeth and close up extraction spaces, or if I have to get these teeth to come back and these teeth to come forward, coordinating arches is where the difficult part of ortho is. But just getting the crowns of the teeth straight, you can get people's teeth straight in 6 months. You might have heard of 6-month smiles, because you can get teeth straight in 6 months. Okay? And what's really happening is when you're in this soft, flexible wire, you're just moving the crowns out to be straight. It's not really moving the roots that much underneath the crowns. So to get the roots to start moving, we have to work up into a bigger, stiffer wire. So that first wire we start with is round. So you picture a bracket on a tooth, it's rectangular, and if it's got a round wire in there, it doesn't interact with the shape of the bracket. It just pulls the crown buccal or lingual or up or down. But it doesn't actually move the root because you'd have to engage that rectangular bracket shape to move the root. So once we get all of the teeth aligned, so the brackets are all basically straight, now we can start to put in a bigger, stiffer, rectangular shaped wire, which when that one engages, now it starts to actually interact with the bracket, and now it can start to torque or move the roots to get underneath the crowns. And then we put in a really stiff wire, kind of like laying down a railroad track. You know, first you got to get all the ties lined up, then you can lay down the rails, now you can move the train. And so once we get into big wires, like this one right here, can you guys see the difference between this wire versus that wire? This is a big rectangular strong wire. Now you can start doing things like putting elastics on here that will move these teeth forward, move these teeth back. But if you put that elastic on a wire like this, you'd have all kinds of crazy movements. Because this tooth would be getting pulled down, it would be rotating. This tooth would be getting pulled up and tipping mesial and rotating. Okay, so you couldn't apply this kind of force when you're in that initial wire. But once you get it to where you have a really strong wire in there, that strong wire can control the unwanted movements. So it can control the rotation and the tipping because it's this nice big strong wire, so that only the force that you want gets expressed, which is these teeth coming forward or these teeth coming back. So in braces, we kind of have this process that we teach you of how do you straighten the teeth, and then how do we get the roots underneath the crowns, and then how do we get the arches coordinated, and then finishing, then get everything to look perfect at the end. So depending on how difficult the patient's case is, some cases all you have to do is get the teeth straight. So if the patient has a good bite, they just have crooked teeth, it's actually not that hard to get their teeth straight. But other patients, maybe getting the teeth straight was the easy part, and then getting the arches to coordinate and closing up extraction spaces, that may be the hard part for that case. Question?
Yeah, so there's only a couple of shapes and sizes for the nine-tie wires, right? The initial wire.
Mm-hmm.
So, I mean, if these patients try on all different sort of solutions, do they sort of all conform to that one?
That's a great question. That's a really great question. So your question is, this really flexible nine-tie wire only comes in so many shapes. And yes, so there's kind of a universal shape for these really early flexible wires. And the reason why is because they do get the teeth straight, but because they're so soft, if you will, they can't apply that much force. They really just get the teeth straight within the shape of that person's bones. So when that person has cortical plate, it's going to get the teeth straight within the shape of their arch. In the stronger wires, we have if you look globally, there's probably 100 different shapes. We carry like 12 different shapes, but what we do is, which is more than most orthodontists do. Most orthodontists will just stock 1 or 2 different shapes in their office. The way that we do it is we diagnose each patient individually, and we pick an appliance. We pick brackets that match their malocclusion, and we pick an arch form that matches their arch, matches their bone, so that we can try to straighten the teeth within the confines of their own bone, unless we're trying to expand them or do something like that. So when we get into the bigger wires have more of because they're stronger, they will definitely shape the arch form more than that initial wire will. So that initial one is kind of a universal. So our like 012, 014 nai-tai will just be a universal shape. But once we get into bigger wires, then we pick medium ovoid or tapered or square or large or small, and we try to either match their arch form, or if we're going to expand on purpose, then we'll pick one that's expanded compared to what they have. So that's a really good question. Does that answer your question? So stiffer wires allows us to apply things like chains and elastics and coils. Aligners are different because we can use elastics from day one. So if the patient needs a class 2 elastic to try to bring their lower teeth forward, we can use that from day one, because the plastic that's covering all the teeth controls the unwanted movements. It controls the rotations and the tipping and all these other things. And so even how we stage treatment is different, you know? And that's one of the challenges with braces is by the time I get to where I can put these forces in to coordinate their arches, we might be a year into treatment. And the patient's happy because their teeth look straight, so their initial chief complaint is gone. And now I'm like, now I need your compliance. Now I need you to wear these elastics to get your bite corrected. And they just aren't compliant. And now I'm dealing with the same problems that I have with aligners, which is they're not compliant. Fortunately, though, we do have some things that we can put in their mouth that don't require their compliance. So there's like a version of class 2 elastics that has a coil in between it. And so even if they don't wear their elastics, I can still do what I need to do. So there's these non-compliance things we have. Okay, but learning what brackets are and what aligners are and how they're different allows us to capitalize on the strengths where they might be strong, and then also realize that they have weaknesses. We can also bend these wires. We can put little twists in the wire. We can put bends in the wire, so we can move teeth when we get up into these stronger wires as well. So I already kind of alluded to this. Fixed appliances, you can see how a wire is deflected into that tooth. And so what's happening here is that there's a force, a gentle force that's pulling this tooth outward. And as long as this patient could move away for a year and come back, and this tooth would be straight. I don't have to do anything. All I had to do was put the brackets on, tie that wire in, leave it alone. That'll get straight. Now with an aligner, that wouldn't work because an aligner is going to have a whole series of aligners, and it's going to be pushing from the lingual surface. Okay, so this one's pulling, and this one's pushing. And one of the other things that's interesting is, you guys who are doing some aligner cases probably see that like the technicians put IPR in all over the place. They put tooth narrowing in. Because a technician will look at this and go, oh, for me to be able to get these teeth straight, I'm going to have to take away some tooth structure so that I have a way to get the teeth straight. But interestingly, that exact same case, if you were to go and just put brackets on here, those teeth get straight without any IPR. So we clearly don't need IPR. We don't have to grind teeth down just to get them straight. So where's the space coming from to get this straight? What do you guys think? So which direction do the teeth move? Yeah, if you have a bunch of chairs and you want to fit more chairs in, all the chairs have to move out so you have room to put another chair in, right? So here, because each of these teeth can move wherever the wire wants them to go, if it's trying to pull this one out, these guys are feeling a force that's telling them to go out. And so they all just kind of move around wherever they have to go until all the teeth get straight. There's nothing restricting their movement. So I did not need any IPR to get these teeth straight. The teeth everything just kind of opens up. Everything moves out, just like everybody pulls their chair out a little bit so that this guy can fit in. But with aligners, they're like, cut away the tooth, cut away the tooth. And when you do your own ortho, you realize like, no, I'm not doing IPR because the technician told me to do IPR right there. And so, we have an aligner that we use. It's actually an excellent aligner. It's progressive aligners. You guys might see something. There's a thing over there. Progressive aligners. Our doctors that have used Invisalign and progressive aligners actually like progressive aligners better. It's a fantastic product. It's a company that's been around for a really long time, but we have our own technicians that work there. So we're not manufacturing the aligners ourselves, but we have a company that's working with us to do our aligners for us. And our protocol says, you will not put IPR in here. If we don't tell you to do IPR, you don't just go put IPR wherever you think you need IPR. You will push the teeth out and you will open it all up, just like the braces do, to get those teeth straight. And then if we, the doctors who diagnose the case, tell you that we want IPR, then you will put IPR in there. But you don't just go put IPR in there just because you decided you were going to make space to get the teeth straight. And that's one of the problems with, sending cases to aligner companies is there's somebody on the other end there who maybe has only worked there for 2 weeks. Or maybe they've been there for 20 years. But normally, the orthodontists who do tons of cases are the ones that get the technicians that have been there for 20 years. And the general dentist who's brand new and it's their first case gets the technician that just started there 2 weeks ago. And so unless we know as doctors what we want, and we diagnose the case, and we are dictating what we want, we're completely at the mercy of, and you know what, it does feel like, well, it's Invisalign. They must know how to do this. They must know what's right and what's wrong to do. So if I just send them a case and say I want the teeth straight, however they straighten the teeth, it must be right because they're Invisalign. That is so wrong. All you have is somebody who's hired on the other side to do what you ask them to do. And if you ask them to get the teeth straight, they'll get the teeth straight. How they did it is not necessarily the right way to do it. And it may not even work clinically. That's why we get education. You guys all remember Smile Club Direct, right? Have you all heard about that? It went out of business. It went bankrupt here a year ago. Smile Club Direct was, why do we need the orthodontist and the dentist? Just get your scan done, and we will give you your aligners. And you know what? That works on some cases, because in some cases, maybe they don't need any IPR, they don't need any attachments, and they don't need any arch coordination, and if they just get their teeth straight, they actually look pretty good. And so they were successful in some cases, but there were a lot of cases that had lots of problems. But I always say, if they took out the middleman and just said, look, all you need is somebody who can scan and then hand you the aligners. But if we, in our general dental practices, if all we do is scan, submit it to the aligner company and say, straighten the teeth, and then whatever they send back, the teeth are straight, we hit approve, and then we hand the aligners to the patient, what are we doing besides just sitting there as a middleman with our hand out getting paid for passing the aligners to them? Our job as doctors is to actually diagnose the case, decide how the case is going to be treated for that patient, and then dictate to the technician and tell the technician what we want, evaluate what they gave us, and improve it until it's exactly what we think is best for that patient. We don't just rely on the technician. I go all over the world, and people come up and show me hey, can you look at this? Can you look at this? And the kind of things that I see, I don't care what company it comes from. I don't care if it's Invisalign. I don't care if it's ClearCorrect, SureSmile, or any one of another 100 aligner companies that are out there. I see setups that I'm like, oh my gosh, that's awful. We need to completely change what they're doing for this patient. And even though we have progressive aligners and we have a whole set of protocols, you still can't just rely on them. It has to be the doctor who knows what they're doing, why they're doing it, what is the reason why you're doing that on this patient. Because what I'm going to do on one patient is not the same I'm going to do with the other, even if their teeth look exactly the same. And we'll talk about that in a minute. It has more to do with the way your face looks than the way your teeth look. Okay? So we have to make decisions on how we want to treat people's teeth. So how does the ortho work? When there's a force applied, either from brackets or from aligners, it's producing tension on one side of the tooth and compression on the other side. So the side that's getting pushed on is creating compression, and then the side that's getting pulled on is creating tension in the little fibers there. That creates an inflammatory response, which initiates a biological response. So then the osteoclasts and the osteoblasts get going, the fibroblasts remodel the PDL, and the teeth move until it finds balance. And that's the other thing that freaks people out. If you've never done ortho, do the teeth get loose while you're doing ortho? Have you ever felt your patient's teeth? Have you ever noticed that they have an easier time getting their aligners out as they go further into treatment? It's not just because they get better at it. It's because when you first put the aligners in, their teeth have no mobility. And so when they go to put them down or pull them off, all the teeth are completely fixed. And once everything starts to get loose, now when they go to put their aligner on and off, the teeth have a little bit of give. And so it's easier to get aligners on and off. And with braces, I mean, like, teeth are loose. They get mobile. And that freaks people out. But that's, you know, so if a patient's like, hey, my teeth feel a little bit loose, you're like, great, it's working. Hallelujah. Okay, because that's how it works. The teeth are going to get loose. And then afterwards, when we're finally done moving them, and we put retainers on, and we stop moving the teeth, and we help the bite get established and balanced over 6 months, we might go and find that the teeth now have no mobility anymore, okay? Because there is no more movement because there's no more forces being applied. And so then they go back to being pretty fixed, pretty rigid. So what are the benefits? Why would you guys want to do ortho in your practice? For me, I just think it's awesome. Like, there's certain things that you do in your practice that you're like, yeah, I get paid for this, but this is the stuff when I see it on the schedule, I get really excited about. What are some of the things you guys get excited about when you see on the schedule? You like doing bridges. All right. Because it's financially productive. You get 3 units for the price of 2, right? And it kind of takes a little bit more thinking because you got to make sure the line of draw is there, and, you know, so that's kind of fun. And then it's pretty rewarding to go seat the bridge. I don't know why that just is fun, but it's kind of fun to seat a bridge, isn't it? When it just fits perfectly, and yeah. What else do you guys like seeing on the schedule that gets you kind of excited? Julian, what gets you excited?
I just started, so right now,
Yeah, composites, yay! And you know what one of my least favorite is like, oh, I have a 14-year-old and I've got like a whole quadrant of composites. I've got MODOs on every single tooth. I was like, ugh. Especially when you're taking insurance plans and when you go and post it and you got like $90 per tooth and you're like, oh, that's so not right. Especially when you get the ones where they also have cervical decay and you're doing buccal, MOD, B. That's just awful. Yeah, right? But they're 14. You're not just going to crown all their teeth, you know? You're just like, where do you get excited when it's on your schedule? Yeah. Yeah, something productive, right? Ortho starts are fun because put $5,000 on the books today, right? Marlene, what do you get excited about? Yeah, because you get the reward of like, you know, if somebody comes in and their part of their tooth's broken off or they've got some old ugly yellow filling there, because you created something beautiful and they're happy and you get that moment where they look in the mirror and they're like, oh, that's great. Yeah, it's fun. Doing veneers, you know, seating a veneer case, it's hard, but it's fun, you know. For me, ortho, like an ortho start is fun. An ortho finish is fun. Ortho checks are fun. Guess what? The patient actually comes in. That excitement you get when you do cosmetic work, ortho is cosmetic work. Every time they come in, they're like, look at my teeth, they're looking better. It's literally cosmetic work. And so how many of you get to do cosmetic work on 12-year-olds? Not that much, right? Like occasionally they fall down and break a tooth or something, but we're not doing that much cosmetic work on 12-year-olds. What about like 7-year-olds, 8-year-olds? What about the 9 or 10-year-old that gets made fun of at school because their teeth are all bucky? And what about the one that comes in and they look sick because their eyes look like this and they breathe through their mouth and their teeth are sticking out like this and they just don't carry themselves well. They don't look good. And all of a sudden that same kid walks in 4 months later and he looks completely different. He carries himself different. He smiles different. He talks different. That same thing when you deliver like veneers and all of a sudden the patient like opens up and you're like, oh, I can see that now they feel comfortable naked. That's what it kind of feels like, right? Where they've been their whole lives like trying to not show their smile, and all of a sudden now they feel like they can just smile and show you something they used to always hide. And so when you can do that on like a 10-year-old, 11-year-old, 12-year-old, 14-year-old, 16-year-old, 20-year-old, 40-year-old, I mean, I've done ortho on 85-year-olds. And when they come in and they're like, this is amazing, They wanted to pull my teeth, and look at what we've done. And I'm like, that's fun. I freaking love that. And so that part of doing ortho, yeah, it's productive. It makes you money. It leads to other things. But you know what? It's just fun to do ortho. It's fun for your staff. It's fun. It brings a different energy into your practice. When kids don't really have any reason to come to the dentist except maybe your toy box. There's nothing they want from you. But if you do ortho, you get 12-year-olds referring families to you. You get a whole new family. They're like, oh, where did this family go? Oh, we're friends with Joey, and he's doing braces with you, and he referred our family to you. And you're like, because you're changing that kid's life, and now he's talking to people about you, and he comes in all excited. You're like, how often do you get a 12-year-old who comes into your office just popping off because he's so excited? But you're doing braces or whatever you're doing, and it just is fun. It makes you a better practitioner because the mouth is dynamic. Before I started doing ortho, I just wanted the teeth to not move. If I'm going to do veneers, if I'm going to do crowns, if I'm going to do a bridge, whatever, it would be better if these teeth were stuck in cement and there was no movement at all. But that's not reality. The reality is it's dynamic and teeth do move. And so once I start to see it as being dynamic, and I'm okay with the fact that teeth move, I know when and why and how they move, and I move teeth on purpose. Now, what I used to be scared of, which was, I hope the teeth don't move, now becomes something that I'm not scared of because I understand it. I have different lenses that I look at when I look at patients because I understand how to move teeth. A lot of positive energy in the practice, definitely increases revenue. And not only does it increase revenue, but also it levels out your revenue. Because a lot of your ortho starts are like, maybe $1,000 down or $1,500 down, and then they pay you a monthly payment. And you're getting monthly payments from the insurance company. And so instead of having a real productive month and a less productive month, it kind of levels things out a little bit more because you have payments coming in on ortho cases. More and better referrals from adults, kids, and specialists, as I told you guys. And then this one, you can't overlook this, it's not just the increased revenue on the ortho you're doing. But every time I say to a patient, hey, have you ever thought about straightening your teeth? We have a conversation, not just about ortho, but we have a conversation about the color of their teeth, about the old restorations that don't look good. Okay, so there's a difference between me just looking in their mouth for things that are broken versus me saying, have you ever thought about straightening your teeth? Because the minute I say that, they start talking to me about their overall mouth and how they feel about the comprehensive approach versus just the tooth-by-tooth approach. And we start having conversations that whether they do ortho or not, leads to cosmetic work, leads to replacing old restorations because they don't like the margin on that crown, just stuff. It leads to more work, okay? And the amount of opportunities that open when you have these kinds of discussions with your patients is huge. You get to prepare your own cases for implants. Like there's so many cases where a patient comes to me and they want veneers on their upper front teeth. And before I was doing ortho, I would just go, yeah, let's do, either veneers on your upper 4. I was never a big fan of upper 6. It was either 4 or 8, because I really don't like ending just on the canines because it just looks like your fake set of front 6 teeth. So I would do 8 veneers on them or 10 veneers on them, and then the bottom teeth were still crooked. And it just never even was discussed really. And now they come in doing ortho, and it's like, yes, I would love to do those veneers on your upper front teeth. And I know you didn't want to do anything on your bottom teeth, but we'll be able to do a much better job functionally restoring your upper teeth if we get those bottom teeth straight, because they do interact with each other. And how about I give you a deal on your ortho on your lower front teeth? So, I'm in control. I don't have to send you to an orthodontist. So I'm going to give you $2,500 to do your lower front teeth because I'm going to be doing the veneers. Or maybe I'm going to make enough off the veneers that I'll do $2,000 for your lower front teeth or whatever. I'm in charge now. And we can figure out a solution. So now not only am I going to do your veneers, but I'm also going to do your lower front teeth. That's increased production. And when that patient goes around to the specialist and all their friends and smiles and shows of their mouth, they're not just seeing, oh, you have beautiful upper teeth, but there's nothing with your bottom teeth. They see a beautiful smile. Everything got fixed the right way. And now that's where people are like, dang, that looks really good. And the specialists are like, oh, he does more than just prep your upper front teeth. He actually fixes everything for you. That's a different level of care. And then improve longevity for the restorative work because you actually align stuff. And then your patients benefit, better facial balance, improved oral health. Do you guys believe that straightening teeth is better for the oral health? You say, yeah, why? Yeah. You get less periodontal disease and less calculus buildup. Like, I have one spot that I need to get aligned. Do you guys, any of you take scalers home and clean your own calculus off? Guess where I have to do all the time? I have one spot that's a little bit crowded, and that's the spot where I am constantly having to go dig stuff out because there's not enough space. You would never place an implant too close to another tooth. Like, we know that you have to have a certain amount of space for it to be healthy. But if the roots are right on top of each other, how healthy is that? It's not. So when you get teeth aligned and you get the roots aligned and the roots are all leveled out properly, so like we have one of our instructors is a periodontist in Holland, and he got in trouble in his local community because he said in an interview, I don't know how you can be a good periodontist and not do ortho. Because the number of things that he can do with ortho, you know, like you have a tooth that's leaned over and there's a big defect right there, and he's like, well, I can grind all the rest of the bone down to the level of that defect, or I can fix that tooth and unravel that defect and actually improve the bone level. And creating space between the roots levels the bone orthodontically. I can extrude teeth like there's so many things you can do orthodontically to get the bone levels healthy. Teeth and bones and gums are healthier long-term if they're straight, if they're aligned. If you get in a car accident and you take your car in to get fixed and there's body damage, but the frame is bent, will they just fix your body damage but leave the frame bent? It makes no sense, because functionally you want to have everything, like you don't put new tires on a car that's out of alignment because they're going to wear unevenly. So teeth wear and break down unevenly when they're not in alignment. So it really is beneficial, more than just aesthetics, to have teeth aligned. And I think as GPs, we fall into that trap of thinking that straight teeth is just cosmetic. And once you start straightening teeth, you're like, it is not just cosmetic. Like, I don't even know how I analyze somebody's mouth and give them an exam without looking at the tooth alignment. Because it is way more than just cosmetics. Like, oh, if you want your teeth to look straight, then you can get them straightened. I'm like, there are so many reasons to get your teeth straight, and one of the benefits is it'll look nice. I don't even see looking nice as the main benefit of getting your teeth straight. I see oral health, longevity, and the way that it's going to wear and function as being the biggest benefit. And then a nice side effect is it looks really good. But that's not the only reason to straighten teeth, right? So we know if things are out of alignment, like it makes sense on our car. But if you look at somebody's mouth and they've got abfraction lesions all over the place and they keep breaking something, you're like, well, it's because it's out of alignment. That's why it's wearing like that. It's out of alignment. If your jaws and teeth were aligned properly, you wouldn't be breaking your teeth like that. You wouldn't be wearing them down like that. Is that from bruxism? Yeah, but it's also from poor alignment. Okay, because you look at tires on a car, is this tire going to wear? Of course. It's on the road, it's driving. But is it going to wear differently than this one or this one? Yeah. Why is that going to wear out, but that's not worn out? It's because it's not in alignment. So when you look at people's teeth, are teeth going to wear? Yeah, they're going to wear because we function with them. But there's a big difference between teeth that are in alignment and the way that they wear over time versus teeth that are out of alignment and the way that they wear over time. These are the kinds of problems we see when teeth are out of alignment and they're functioning on them versus teeth that are in alignment and functioning. Okay, so this kind of stuff, even, because if you guys look a lot, which molars are the ones that get beat up all the time? It's the 6s, right? The ones that you'll see with root canals on them, and because they're frequently out of alignment, and the way that the patient functions on that tooth just beats the crud out of them. Okay? They were the first ones into the mouth as far as the posterior occlusion, And so if they came in and they're out of alignment, they just get beat to snot. Periodontally, we just talked about, if roots are on top of each other, it just doesn't have the same effect, you know? So trying to keep this mouth clean and healthy versus keeping that clean and healthy is way different. When there's space between the roots, it's not just that your hygienist can clean easier because they can get their scalers in there. The patient can clean easier, and calculus just doesn't build up when you have, yes, it builds up. It builds up differently when the teeth are right on top of each other than when they're spaced apart. And then beyond tooth wear, you guys maybe have seen those patients. I don't know, I see this all the time, but you may not have even seen this, where the patient comes in and they kind of have their jaw off to the side and they kind of like talk through the side of their mouth like a pirate. And because when you look at their mouth, their maxilla was a little bit too narrow. And so when they bite, they would end up hitting cuss tip to cuss tip. So they shift their jaw so that they have a crossbite on one side and there's no crossbite on the other side. But if you actually seated their condyles, they would be hitting cuss tip to cuss tip. So it looks like a unilateral crossbite because there's only crossbite on one side. But the reality is they're shifting their jaw to fit like that. And if we got their jaw seated properly, they would be insufficient overjet on both sides. So you catch that on a kid who's 8, 9, 10, 11, 12 years old and fix it, and they literally develop differently. Their face will come out looking differently than the one who developed with that all the way through until they were in their 20s or 30s. So we have tremendous opportunities to intervene in facial development, in function, kids that are lip incompetent who are mouth breathers. In fact, I'm going to give you just a tiny little tidbit. It's fascinating to me. Have you guys ever gotten into breathing? Like there's a book called Breathe. Or maybe like anybody who's into meditation, there's like people who do breath work. Like getting up in the morning and doing like nose breathing is like a really big deal. And there's this fascinating book called Breathe where they go into mouth breathing. But are you guys aware of some of the problems that mouth breathing kids have? They're neurological problems. It goes beyond just like, oh, well, it doesn't look good for you to breathe through your mouth. They have neurological problems. Learning problems, bedwetting problems. They have actual like neurological problems. And so I'm learning more and more about the cerebrospinal fluid flow through the brain and how we actually cleanse and detoxify the brain with the cerebral fluid flow. And one thing I didn't know was that 70% of the drain, so like when we clean our brain and then we need to get rid of that stuff, it actually goes through the cribriform plate, which is where the olfactory nerve goes through, right at the back of our nose, like right inside here on the back side of that. That's where all of the brain needs to drain down through here. And so I was like, so all this breathing stuff, like yes, it's good to get the oxygen into you and whatever, but when you're breathing, the motion of breathing, and especially when you flare your nose to be able to get the air through your nose, it actually moves things in this area to where your brain is actually able to clean itself. And so the kids who never breathe through their nose are having neurological problems because their brain isn't detoxifying. That's wild. And so you all of a sudden go and take somebody who can't breathe through their nose, and either through help from an ENT, help from a myofunctional therapist, and then help with you getting their teeth to where they can actually function properly. You can take somebody who's not able to actually detoxify their brain and actually help give them better brain function. Like that's massive. I actually worked in my practice with a myofunctional therapist. So if I had a kid who wasn't breathing through their nose, if I'm like, close your mouth and let me hear you breathe through your nose, and they're like, they can barely breathe through their nose. It's like, hey, they're 10 years old. We need to get this child breathing through their nose. Okay, so through me doing the proper ortho, through them going to see a myofunctional therapist and learn how to use their mouth properly, and sometimes the intervention of an ENT, whatever we have to do, they have to be able to use this because this actually has a tremendous impact on how they develop their face. And I'm finding out even more now about how they actually function neurologically, about cleaning their brain and actually allowing the fluid to flow properly. So there's a lot more to ortho than just making people's teeth look pretty. So ask yourself in your practice, how many ortho cases do you refer out each month? How many ortho conditions go undiagnosed in your practice because you just don't see or talk about ortho? How much potential production is being lost because it's not part of your evaluation in your practice? I found out that my practice was a gold mine of opportunities that I was just allowing to flow in and out because I wasn't talking about ortho with my patients. And then once I started coming to these courses, I went back and got my staff on board, got them super excited, helped them to learn some of the things that I was learning. We had lunch and learns, and I would train them and teach them the things that I was learning, and started treatment on staff member. It's the easiest way to get the buzz going in the practice is like, oh yeah, Debbie up front, she's getting braces, she's got aligners, whatever. You know, so you start on family members, you start on a staff member, and you get the process going so that you learn, oh, even just like, how do I submit this to an aligner company? How do I order the brackets? How do, you got to get a system in place for all this. Who's going to bill? How do we do the insurance billing? And once you get the system in place, it's like you've created the riverbed. Now water can start to flow down that. So doing the first few cases allows us to start to have a process. And like you have a really good process in your office for doing aligners, but when you finally do your first bracket case, then you're like, I had to create a new path. And once I've established the process, now it's a little bit easier to go, oh, this case would really benefit from doing some brackets on it. One new ortho case per week. To me, that's not an unreasonable amount. Like one patient a week who's like, I would like to do ortho. It's a lot, but it's not unreasonable to have one. If you're talking on every patient, hey, have you ever thought about straightening your teeth? You're going to have one patient a week who wants to start ortho. You know, the average ortho case fee, I don't charge less for my ortho than my local orthodontists do. Okay, because I'm going to do as good or better job, and I'm also going to see them every 6 months afterwards for the next 20 years. So I'm a little bit more invested in making sure that things work out well than even my orthodontist is. Because you guys have all seen patients come into your practice who like, teeth aren't straight anymore, but they know if they go back to the orthodontist, they're going to want to put braces back on and charge them more money, so they just don't. But if they're my recall patients, they're coming in anyway, and they're going to be talking to me about the things that aren't working out well. So I'm very committed to their long-term success. So let's say you charge anywhere from $5,000 to $7,000 for a case. You're looking at an additional $260,000 to $365,000 per year at a conservative one case per week start. But that's not even including the additional services that you'll provide as a result of doing ortho treatment. Not also, if you're starting ortho cases while you take the education, you know, how about those doctors that start 100 cases while they're doing a 2-year program with us? By the time they're done, they started 200 or 100 cases. You think their education and all the equipment they needed got paid for? Way more than got paid for. You only have to do a couple cases to pay for the education and pay for the equipment that you need in your practice. Okay? But it does take a commitment of like, I want to do this. I'm all in. So some of the other sources of revenue, periodontal procedures, grafting. You guys all know if your orthodontist wants to do ortho, don't they send you guys general dentists that you have to basically sign off on the perio and the caries before they start? So same thing in your practice. Like if they want to start ortho, they have to be free of gingival disease, periodontal disease. So sometimes there's scaling and root planing, whatever it takes to get their periodontium healthy before you start ortho. And then if there's any caries, you need to get that under control before you start ortho. So sometimes if there's crowns, you know, I'll do like a temporary crown cemented with permanent cement so that we can get through the ortho. And then at the end of ortho, I'll make the new crown for that tooth. Because I want to make the new crown fit all the straight teeth, not the crooked teeth. So there's a lot of opportunity. When you're going to start ortho, if the patient's interested in straightening, it initiates a lot of things that have to happen to get them to be able to do that. Lots of opportunities to set up cases for implants, for restorative work after the ortho. It always leads to cosmetic work because the minute they get their teeth straight, things that didn't bother them before, like that crown margin, like the color of that crown. Now the teeth are straight, they want everything to look nice. And so now you're getting into some cosmetic work that you might not have been doing. Retainers, splints after ortho, future relapse if they didn't wear their retainers, referrals. There's a lot of different opportunities to increase your revenue through doing ortho. So I agree with Dr. Lee here, adding ortho was the best decision of my career. And this is from one of the brochures that you guys have out there about our seminars. But improved care, boosting profits, and meeting patient demand. The reality is that patients, I tell them all the time, like, look, I'm not an orthodontist specialist. I just do a lot of ortho in my practice. We have some great specialists in town. If you'd like a referral to one of the orthodontic specialists to get another opinion, I'd be happy to give that to you. And sometimes they take me up on it. And every once in a while, they actually do have the orthodontist do it. But 99% of the time, they're like, oh, no, if you do it, like, we would want to do it here. They already like you. That's why they're in your office. They trust you. They like your staff. This is where they come. And if you can confidently provide a service for them, they would much rather you provide that service than go get to know a new office and figure out whether they trust that office or not. They want you to do it. So if you can confidently provide the service, they're thrilled that you'll do that for them. So learning ortho for me is like a no-brainer. It's just one of those things that helps you, every patient, whether they do ortho or not, you're going to learn something that you can do better for that patient because you learned ortho. So let's dive in and remove the mystery and help you guys see that you can do ortho at or above the level of the specialty. That's our goal, is that you do orthodontics at or above the level of the specialty. Because isn't that what, you shouldn't do a root canal if you can't do it at the level of your specialist. So if I know I can treat that tooth as well as my endodontist, I'll treat it. But if I'm like, that patient would get a better root canal on that tooth by my endodontist, like, you're going to the endodontist. So I feel confident providing services to my patients if I feel like it's going to be as good as the specialist would do for them. If not, why would I not send them to the specialist? So that's our goal, is to, if you're going to do ortho, take proper records, diagnose your cases properly, have mentors to back you up, like, do high-level ortho. The case